We'll move on to our next session. It will be a panel or case presentation. It will be led by Dr. Sanjeev Sabharwal. So I call our panel speakers to sit up front, please. So Dr. Sabharwal is one of our pediatric orthopedic surgeons. He trained for orthopedic residency at University of British Columbia, followed by a fellowship in pediatrics at Children's Hospital LA and Shriners Children's Hospital. He also completed a second fellowship in limb lengthening and reconstruction at the International Center for Limb Lengthening in Baltimore. At UCSF, he is our director for the Multidisciplinary Limb Lengthening and Complex Reconstruction Center at Benioff Jones Hospital in Oakland. He will be joined by Dr. Kathryn Sigford. Dr. Sigford is a pediatric physical medicine and rehabilitation specialist. Dr. Sigford earned their medical degree at UC Davis and completed a residency in pediatric physical medicine and rehabilitation at Stanford, followed by a fellowship in pediatric rehab medicine at University of Minnesota Twin Cities. Dr. Sigford sees children with conditions that include CP, brain injury, spina bifida, spinal cord injuries, neurotrauma, torticollis, and gait impairment. Also part of this panel is Brent Hisaka. Brent is a physical therapist who specializes in caring for children who want to start and maintain or return to an active lifestyle. Brent earned his bachelor's degree for exercise biology from UC Davis, and then his doctor of physical therapy at Samuel Merritt University, and is board certified orthopedic clinical specialist. In addition to treating sports injuries, he is the physical therapy lead for the Pediatric Limb Lengthening and Complex Reconstruction Center. And then last but not least, we have Alexander Geraldi. Alex is a physician assistant who cares for children and young adults undergoing orthopedic surgeries. Alex earned his master's degree in physician assistant sciences at Loma Linda University. And he treats a wide range of musculoskeletal conditions and is part of our Limb Reconstruction Center. So I'll pass the mic on to Dr. Sabharwal.
Okay, great. All right, thanks, Dr. Deborah. And as Dr. Deborah said, we're lucky to have panelists who are very well embedded in the sort of limb difference center here at Children's Oakland. So the format's going to be a little bit different than the previous few talks in that we're going to show a few cases and then open it up for discussion, ask you guys if you have any questions, and then also pick on our panelists at appropriate spots. And I was listening to the last section, and it was a perfect segue because this thing came up with bow legs and blunts, etc. So let's get started. And I'm assuming the audience is a combination of physical therapists and primary care physicians, right? How many physical therapists in the group? Oh, nice. And primary care? All right, perfect. All right, let's get started. And please, you could just speak up at any point. You could raise your hand and, it's going to be, I think we've got about 45, 50 minutes. Yeah, 50 minutes. So yeah, we'll just go back and forth. And I've got maybe 3 or 4 cases that on 2 themes. So we'll get started. Okay, if I can figure this. Oh, there we go. Oops, too much. I'm going to get it. Okay, my disclosures, case 1. So this is a 4-year-old boy who presented to us with left-sided bowed leg, okay? So, so the question is this physiologic? Is this pathologic? Why do you think either of those options? And what would be the next steps? So we'll just open it up. Can you guys see? You can see the screen, okay. Anybody? Okay, let's start with the first part. Is this physiologic or pathologic? How many say physiologic? Okay, so it's pathologic. And why do you say it's pathologic? One-sided, unilateral. Okay, what else? Well, age, perfect, right? So like Dr. Livingston said earlier, 18 months to 2 years. So, one side straight. Even clinically, if you look at the left picture, and the other one looks bowed. Okay, so any sense of what it is? Diagnosis, we'll just jump ahead. What could this be? Oh, awesome. Who said that? All right. Why do you say that? Little louder, please.
The medial tibial physis looks a little sick.
Okay, awesome. I don't have a pointer, but I could just walk up and you're talking about this part?
Correct.
Right. Excellent. Okay, that's what it is. And so what would be the next step? Refer. Awesome. Okay. All right, good. Okay, any of our panelists want to say anything about this? No? Okay, we'll just keep going then. Okay, so you're right. So Blount's disease for exactly the same reason you said, right? So Blount's disease, for anybody who doesn't totally know this, is a growth plate abnormality. It's considered a developmental problem, not a congenital problem. And it happens with growth. And the growth plate around typically the proximal medial aspect of the tibia is sick. It doesn't grow as well as the rest of the growth plate, which then biologically creates this ongoing deformity, right? Okay. So, okay. So there's two types, just like scoliosis, like there's early onset, late onset, right? So early onset is having these Blount's like clinical picture before age of 4 years in terms of onset. Late onset is anytime after 4. That can be subdivided into juvenile and adolescent, but that's really not very consequential. But early onset and late onset are very different diseases. Okay, so what do you recommend? Observation, a brace, like a knee, ankle, foot orthosis, guided growth, which we'll talk about a little bit more, which is like a hemiepiphysiodesis, or an osteotomy, which I think you all know means cutting the bone and straightening it out. So maybe I'll just poll, how many for observation? Okay, you got to raise your hand at one point for these 4. Okay, how about for bracing? Okay, and guided growth? Look at that, and osteotomy. Okay, you guys are so good. I should stop. There you go. All right. So yeah. So what is the concept of guided growth? Anybody wants to take a stab at it? What is guided growth?
Is that watching with the orthopedics, like looking at the x-rays and alignment and serially, I don't know, every
Yeah.
3 months, every 6 months?
Yeah, it does involve a procedure. Yeah, but you're right. That's the concept, is you sort of guide nature, but you have to do something to manipulate the physis so there's differential growth in the other direction, right? So here we said the medial side of the physis was not working. So where would you put an implant, sort of like a dental procedure? Where would you put an implant to kind of guide it? On the other side, right? So you put it on the lateral side. So that's the fancy word is hemiepiphysiodesis, but that's what it is, right? Okay, I simply can't. Okay, we'll get to the bracing. Okay, let's start with bracing. We'll run down the list. So bracing can work, sort of like scoliosis, right? Something is flexible, the kid's still growing, you kind of just tweak it a little bit. But in reality, a lot of these children don't tolerate a brace, just like they don't tolerate the nighttime stretching splint, for heel cord tightness. And the question is, how long do you keep it on? When do you keep it on? Is it daytime, nighttime, all the time? And then, the studies that are out there are kind of confusing because sometimes it's hard to say in a 2-year-old, is this really physiologic or is it early onset Blount's? So some of these patients who are included in series with bracing are actually, you could question that it's probably not even Blount's. So the water is very muddy, but the general feeling, I think, for most pediatric orthopedic practices is that bracing doesn't really work that well. Doesn't mean it should not be tried ever, but at least in my practice, it's not that commonly done. Okay. And so these are all the reasons we talked about. Okay, so guided growth is based on a couple of biologic principles based on biomechanics and growth. That if you squish or compress a growth plate for a certain period of time, it's going to cause growth inhibition, right? So what you're doing is you're differentially, again, compressing the growth plate on the other side so this side can grow. And I mean, this is really taken off after these implants, which is a simple little plate with 2 screws, came about. In the past, we used to use staples, which would back out and not be that effective. So once the implants changed to screws and this extra periosteal plate, so you can think of it like an internal brace. So it's there, but the concept is that not that it's a permanent thing. Once the leg is straight, then you can take it out. So there's some inherent reversibility in it. And it's a same-day procedure. Unlike an osteotomy, which is a bigger deal, you still have the recurrence, et cetera. So, and again, it's best to use it when the growth plate is sick but not dead, right? So it's still got some potential on the sick side to wake up, is when you would use, and obviously the kid needs to be growing. So when is it not indicated? If it's a huge deformity in an older kid, and especially if there's a huge leg length difference. Because just doing a hemiepiphysiodesis isn't going to correct the leg length, unlike an osteotomy with lengthening. So this is what it looks like. And we've done a little arthrogram in the operating room. So you simply put a little screw in the epiphysis and the metaphysis, and it's literally a half an hour operation. The kid can weight bear right away and go home the same day, compared to osteotomies and things. So, very sort of straightforward procedure for the most part. And, but then you got to tell the family the leg's still going to look the same right after the surgery. It's over time, right? And follow-up is key. So we intentionally then overcorrect the leg from bow leg. So this is in a matter of 14 months. See, it went from bow-legged to actually intentional knock-kneedness. And that's intentional because the kid's only 5 right now, and he's going to grow till age 15, 16, right? So you don't want to leave this in, otherwise he's going to get way overcorrected, and that's not good. So, but you sort of, and that's the art and not so much the science, you sort of overcorrect it a little bit depending on a multitude of factors. And then you take the implant out, which again is a same-day procedure. And just like we saw in this case, there's a little bit of a rebound growth, which can happen. It's sort of like a pressure cooker. You suddenly take the lid off and, the steam or the growth sort of rebounds. Doesn't always happen, and that's the little unpredictability. So you don't want to leave these implants in for many, many years, right? Because then you could have a permanent problem with the growth plate. Okay, another kid with Blount's, very, simple, straightforward, easy diagnosis, right worse than left. You can sometimes do an advanced imaging. And when it looks like there's nothing on that medial side on the growth plate or on the proximal tibia, like right here, if you did an advanced imaging or an arthrogram, which is, putting a little dye in the joint to sort of look at the outline of the cartilage, which is not radiodense, you'll actually see that there's cartilage there which is unossified, right? It's not turned to bone yet. And then the meniscus is a little thick, which really doesn't matter. But so this is a different problem, right? So here it's too severe, and we said guided. So in this kid, I think on the one side we did a guided growth, and on the other side we did an osteotomy, but not just an osteotomy, because the more severe the deformity, at least in Blount's, the more it is associated with limb shortening, right? Because it's a physis that's not growing. So it's not just growing in angulation, but also in length, right? So here, this child needed sort of a multiplanar correction, not just in the frontal plane, but also in the sagittal or the side plane, and needed length. So here, we did a gradual correction with external fixation. So I'm going to stop there and pick on our panelists here a little bit. So maybe I'll start with Alex Geraldi, who is our physician assistant lead. So Alex, what's our postoperative protocol for a patient like this?
Yeah, sure. So initially, these kids are obviously operative post-op day 0. We finish up in the operating room, and from there, it's transitioned to the floor. I like to kind of look at these next 7 days as pretty much really just treating the patient and not necessarily treating anything in regards to like osseous or bone standpoint, because it really is important to get these kids kind of understanding what's going on over the course of potentially the next like 3+ months. So initially, post-op day 0 is really just making sure they're comfortable. So pain management is really important, making sure that they're understanding ultimately what's on their leg and what will be there for the next 3-ish months. So it's care for the parents, it's care for the child, and making sure they're comfortable. And then from there, as we look forward kind of post-op day 1 to post-op day 6, 7, it's making sure that they're understanding the frame and how to care for the frame. Not only during this time is important for education, but this is also where physical therapy comes in and plays a very important role in just teaching children and family, specifically parents, like what this movement is going to look like, how they're able to get both out of bed to the bathroom, transitioning to school, and just getting them comfortably from a mental standpoint. Once we kind of get to post-op day 6, 7, this is where we start talking about healing occurring and ultimately wanting to start the actual gradual adjustment. So what's on the child's leg is an external fixator, and through that device, we utilize very small millimeter-type movements that help to correct this deformity, and this deformity gets changed over, again, months at a time. So we provide them with this schedule and how things will look over the next month, and then we explain to them how to actively utilize this external fixator. So it's a very extensive process, but traditionally, starting post-op day 7 is where we begin to lengthen. We have them start cleaning the pin sites. So there's 6 half pins is the term that we use that are attached to the leg, and teaching them how to care for these pins over the course of the next 3 months, and then teaching them the schedule, and then ultimately them understanding weight-bearing precautions again through physical therapy is kind of how things look initially.
Thanks, Alex. And I'm going to carry on with the discussion and ask Dr. Sigford. And as I said, we are sort of a very comprehensive team with multiple specialists in here. So, excuse me. So Dr. Sigford can tell us about inpatient rehab, which we have a unit.
Yeah. So Alex alluded to getting these kids back to being able to be mobile, figuring out how to get around, how to get out of bed, do all these things with this large frame on their legs. And depending on the size of the kid and the amount of work Dr. Sabharwal has done, sometimes the frame looks bigger than the kid, and it can be a bit of an intimidating prospect. So very often we bring these kids to acute inpatient rehabilitation for some portion of the 7 to 10 days that they're in the hospital. That lets them get into the intense physical and occupational therapy services that are available to an acute inpatient rehab kid. They're generally good candidates because these are kids who are otherwise in good health and able to participate. They are kids who were previously functioning well and now have experienced a decline in functioning. It is an intentionally surgically caused decline in functioning, but it still is a decline that they need to learn how to work with. Generally, the surgery is done on a Thursday. The rehab consult is called on a Friday, and they admit the following Monday. They will then stay on rehab for the rest of that week, maybe into the next week, depending on how long it takes the child to learn to mobilize, the parents to learn to care for the frame and the child, and for everybody to feel comfortable with going home. We use that time to have the physical and the occupational therapists work on how to be on the basic beginning of mobility skills, on how to get dressed, how to get a shower, and all those basic everyday things that all of a sudden have become a much more daunting task. The orthopedic nurses also do a really good job teaching the families how to take care of the frame and greatly reducing the anxiety and stress that everybody has around this. We often see kids go from terrified of the whole thing to wanting to do their own pin care during the course of the rehab.
Great. Great. Any questions? Because I know this is a little different and it kind of scares the kids and the parents and sometimes the primary caretakers too. So, all right, so let's keep going and we'll pick on Brent in a minute. Yeah. Okay, so there she is, legs are straight, but it's not over because remember, the growth plate was sick. So, we still have to watch her over the years to see, and there is a chance some of this may recur. Okay, so here's one where things didn't go as planned. So I wanted to show you not just the good cases, but what happens when we don't play by the rules or others don't play by the rules. So a little older kid, 7-year-old, Blounce, again, pretty classic, right? Both sides, right worse than left. And you can see the right side is shorter, and that's why we have a picture with him standing on a lift just to level the pelvis. And by the way, that's how we get x-rays also. So if you look at the x-rays, the pelvis is level, and that helps us sort of more accurately measure all the lines and angles as opposed to somebody standing with a tilted pelvis and a flexed knee on the long side. So anyway, this kid was a great teaching case. 7-year-old, so we opted for a guided growth on the left and and an osteotomy on the right. And if you look at the follow-up in the bottom, this is at my previous practice, and so 2009, and he came in 9 months. He was starting to recur a little bit on the right side. The left was nicely correcting, and then he missed follow-up. So, again, guided growth, follow-up, very important, right? So here he is. He's got this so-called windswept deformity. So what happened? The right side actually got worse. The left overcorrected. So it went from bow-leggedness to knock-kneedness. And guess what? He's getting older. So what did we do? We took that broken plate out on the left, and on the right, oops. Okay, I don't know how to drive this. On the right, we did this thing called a tibial plateau elevation. So it was a much bigger deal than a guided growth, where you cut the bone in the joint, lift that plateau, medial plateau up, and put a chunk of somebody else's bone, allograft, and then fix it with plates and screws. So a big deal. And then on the left side, all we did is take the implant out, and you could see the power of the growth plate, right? So the growth plate, the plate was gone, the implant was gone on the left knee, and so it went from bow-leggedness to knock-kneedness, and now it's sort of going back to bow-leggedness on the left side. And then it just kept going on the left. It went, so it went, and so why did that happen? Because as the kid grew, that so-called reversible changes in the growth plate became permanent, right? So as kids get older, some of these, and that's why it's good to see them early, because when they get permanent, then even, so there's no growth potential on the sick side. So he ended up having another plateau elevation on the left as time went on, and then here he is at skeletal maturity. So, a little bit of a win. After all these procedures, the legs are straight and he's done growing, so hopefully he's not going to recur. But some of this is related to not seeing him for one reason or another, in the follow-up that was needed, right? And actually, the other is that he presented late. He was age 7 compared to age 4. So when you see someone like this at age 3, 4, and their legs aren't meant to be bowed anymore, then obviously, you got to think of it, especially if it's unilateral, but it doesn't always have to be unilateral. So what's the lesson learned here? One is that growth modulation, while a technically simple operation for the most part for the orthopedic surgeon, is really can turn into very complicated problems if you don't do the right patient selection and you don't sort of chase them if they miss their follow-up. So that needs to be done. And a reversal, and the second part, as we saw in this patient's left leg, something that's reversible at a younger age with time can become irreversible. So again, early diagnosis is good. Okay, any questions? I'm going to move on to how much time do we have?
Till
Okay, good. Oh, yeah, we got time. Okay, so this is, so just one more case, and then, we're gonna open it up for more questions. So this is, again, a growth plate problem, but this one's a fracture, okay? So this was actually, in our practice, one of my partners was presented with this 10-year-old with a Salter-Harris 2 of the distal femur fracture. I think you can all see it, right? It's subtle, but not that subtle, right? So it's like that. So she's 10, she had this and got appropriate initial treatment, which is, a close reduction and these smooth little wires and a cast. So smooth because you don't want threads to go across the growth plate because that can cause more permanent problems, right? Anybody wants to take a guess what could happen to this fracture? Like what's a long-term problem? Oh, I'm so sorry. Here. Oh my God. Now. Jeez. So sorry. Okay. Go ahead. Yeah, sure. So what's the long-term problem with this kind of a fracture, which is a growth plate fracture of the distal femur? And by the way, how fast does a distal femur grow? Is it like in the top one or two fastest growing growth plates, the most slow growing growth plate, or somewhere in between? So it turns out to be the fastest growing growth plate, okay? So you've got an insult to, and this growth plate, unlike a distal radius, is more sort of up and down. It's not a smooth little growth plate, and it takes so much more energy to break a distal femur than a distal radius, right? So if you put it all together, so here there is a growth plate fracture in a growing child, in a fastest growing growth plate. What can happen? Yeah, go ahead. Yes, exactly. So they can have a premature physeal arrest, right? Okay. So that's what happened. So so one of my partners tried to control that. So, and interestingly, this is a little complicated, that it's not just a frontal plane problem like bow legs or knock knees, but you got to look at the side too. So on the side, she had a growth plate in the back of her distal femur, so the front kept growing. So the leg got short and it was bent, right? It was flexed. And initially, they thought it's a flexion contracture. But I'm going to ask Brent that, is this a contracture or is this a bony problem? And I know it's a little bit sort of beyond your thing, but okay, I'll start by saying, why is it not a contracture? And why should a patient like this not get physical therapy as the primary mode of treatment? And by the way, we haven't preempted, so this is accurate.
It's not a contracture because the knee functionally can't go any farther. So we could stretch it as much as we want, but we're just going to be jamming up into this, ill-formed knee. So physical therapy is not going to be the primary mode of treatment for them.
So thank you, and sorry for the setup. So this is, and that's what happens a lot of times. It's a bony problem, and they're like, okay, the leg or the joint or whatever cannot get straight, so let's just do physical therapy. But at some point, we have to recognize if it's a bony problem, therapy is not the answer. If anything, the tissues are going to try stretching out to compensate anyway, so you don't want to do that. So she underwent an external, because the leg was short, it was multiplanar deformity. So once again, this is not our sort of first mode of treatment, but when nothing else seems to work, then we got to go to the big guns, which is external fixation, gradual correction, inpatient rehab, like Dr. Sigford and Geraldi said. And so, but here's a problem. So I'll just fast forward. We got her leg straight, but it was a little short. She was still short. And she's like, I don't want this monster on my leg. Take it off. So it goes back to, what Dr. Sigford was saying, we got to counsel them appropriately. and then have a backup plan. So maybe very briefly, Dr. Sigford, how do you assess and counsel preoperatively to see if this patient and family can go through the journey?
Well, even before you talk to them, you can look and see what has happened with treatment for problems previously in their life. Has this been someone who has been sent to physical therapy and missed half of their visits and rescheduled the other half 6 times? Has this been someone who has missed multiple appointments? Is this someone who is there on exact time, every time, has done everything you've told them to? There's your first thing to look at. Where is the family starting? Second is to make sure that you really give them a clear picture of what's going to happen and what might happen. There is going to be this very large, enormous frame, and I hope you have one in ortho that you show people. I figured. And that it will be there for months and months, and if you don't make it through to the end, you will not get the results you want, and maybe you shouldn't have started in the first place because you will have worn this thing for a while for no good reason. I find that as much as my natural tendency is to want to be very soft and gentle and sugarcoat things, there is a time and a place for saying, this is what will happen, this is what needs to happen, and you need to understand that. I think so part of it is as well just on our side avoiding vague language. Like, gosh, we think this could take about 3 months, but we'll see, and then it could be good. It will be at least 3 months if you want it to work.
Yes, perfect, yeah. A little bit of militancy doesn't hurt. Okay, thank you. Here we go. Okay. Oh my God. All right. So the leg is straight, both in the front and in the side. She actually has full mobility, and she actually disappeared for maybe 3 years or so. There was some, situation with housing, psychosocial problems, et cetera, et cetera. The parents were going through some rough times. So now she comes back, actually more recently, last year, and says, my back hurts and I have a leg length difference. I don't want to use a shoe lift. What do I do? So I'm going to ask both Dr. Sigford and Brent very quickly to talk about shoe lifts, because that's a common problem, right? And there's many issues to this. Do you get an over-the-counter thing? Do you just get a little heel thing? Do you get it full length? How much can you put inside the shoe? How much do you put on the outside? Who do you ask for a shoe lift? Do you just go on the internet? Do you send them to an orthotist? Or do you just simply send them to a cobbler, which are very hard to find these days? Yeah. Okay, well, that's, okay, where's, all right.
Berkeley.
There you go.
The first question is, how much difference do you need to make up? In most shoes, you won't fit more than about 1 centimeter or half an inch comfortably, and even that in the heel of the shoe. You'll get that much distance as a full-length lift. It will be much harder to get through the full insole. The shoes aren't that big, and the feet take up most of the space. So your first question is, how much difference do you need to make up? If you can do it inside the shoe, that would be where you want to do it. And if you just need a small one, you can buy a heel lift over the counter or from Amazon, because Amazon sells everything. And with the appropriate guidance from your physician, you can get the right height and get it in there. Real cheap, real simple way to go. You can have as many as you have shoes and not be losing it and changing it from shoe to shoe. If you need a full length one, those are a little harder to get over the counter, but still possible. You may end up starting to need to work with an orthotist depending on the exact dimensions. About 4 months ago, I saw a guy who was having pain, migratory pain. Every part of his body hurt some point in every day because of his leg length difference. For him, I did use an orthotist because I wanted I wanted to keep the lift inside the shoe, but he was right at that margin of what would do it. So I went as thick as possible in the heel, tapering down towards the toe because there's less space in the shoe in the toe box than there is at the heel. Go outside the shoe if you have to, if you can't fit it inside, because that way, once you've modified the shoe, you can only wear the shoes you've changed over. And how many pairs of shoes are you going to change? Not as many as a lot of people want to wear. Most insurance won't cover. Most cobblers will be cheaper than most orthotists. If you can find a cobbler who can do it, that's your choice.
All right, great. Brent, any other words of wisdom?
So the other thing that we consider when we're looking at from an outpatient physical therapy perspective is, especially if they're right on the edge of, what kind of shoe lift that they need, we're also going to look at the patient and see, is the leg length discrepancy actually what's causing their pain? Maybe they have a very subtle leg length discrepancy, but they have all of these other compensations or muscular weakness, movement pattern dysfunctions that we could address first, especially if, say, maybe this family is financially limited, they can't afford, or they're going to have difficulty affording, shoe lifts or a cobbler or something like that. Like, hey, we could try and correct some of these deficits first, see if that completely resolves or improves your problem to a level that you're satisfied with, and then you don't have to go and, look into external supports like shoes.
Great, yeah, and one last point, like a lot of kids and patients who have had a leg length difference for their lifetime will have a tendency to walk on their tiptoes on the short side. So if you just give them a heel lift, you're actually perpetuating that equinus contracture. So if everything else is equal, I think a full length lift for the short side makes more sense, at least for me. Yes, go ahead. Okay, well, that's good to know. And I think at least in the East Coast where I was practicing, a lot of insurance companies will pay for a shoe as well. I don't know if that's the case here or not. Probably not. Okay, good. Anything else? All right. So
The key, if you're going to get insurance to cover the shoe, you've got to make it very clear in your note that the modified shoe is a critical part of your medically prescribed treatment. It still may not work, but you won't have any chance otherwise.
yeah. Okay. Good. All right. So here she is. She didn't want to use a shoe lift. She did have back pain. She did have a significant leg length difference. So, what's significant? I think anything more than 1.5 to 2 is significant, especially if it's associated with an angular deformity. This one was not, did not have an angular deformity at this point. Okay, so this is what we did. So so this is towards the last part of this talk. So, we have evolved. So yes, we showed you a couple of cases of external fixation and, the psychosocial toll it takes. And it's not great for muscle impalement by the half pins, et cetera. So as you probably may have heard, so now there's a new implant in the market, which is internal magnetic lengthening nail. I don't have any financial ties to it, but I tell you, it is a game changer for the femur. So now for the femur, if everything else is equal, we try to do an intramedullary magnetic lengthening. And it's so there's much better patient experience. There's physical therapy involved, but it's much less. But there are obviously downsides and certain things you cannot do with an internal lengthening nail that you can do with an external. So here she is. We just put this rod, and I don't know if you guys can see it from the back, but it's sort of a telescoping rod, and there's a magnet in here. So what the patient and the family does is, instead of turning, knobs and struts, et cetera, they just put this thing called an ERC, external remote control, on the thigh. We just sort of have a sort of a cross on the thigh where the magnet is in the nail. And they push the on button, and it goes on for like 90 seconds, and the nail automatically lengthens. And so they do it, 2 to 3 times. So, here's technology that's sort of evolved. And as I said, it's a game changer. But again, you can't use it in a 3-4-year-old. And it's more effective in the femur in a kid because you could put this nail at the greater trochanter, and you don't have to sort of go across all the other growth plates. In the tibia, it's a little bit more challenging because, there's growth plates on the top and bottom. And so unless it's nearly skeletally mature patient, the tibia is not as reliable or as indicated. So there she is. She maintained her knee mobility and had actually a very smooth course. And I tell you, I've had a whole bunch of patients who've had both devices, have had an external fixation and internal, and there's no question that this is a better experience for them. And so here she is 3 months later, and her legs are straight, and she maintained mobility. And at the first sort of lengthening time, she was an inpatient rehab patient. I think the second time she was outpatient rehab. So there we go. And then, so what's the take home? Limb reconstruction, as you can see, is a team effort. A surgeon cannot do this because you need therapy, you need rehab, you need psychosocial. So we have a social worker, we have a child life, we have an orthotist. So everybody has to work in unison. And they need to be sort of, in sync with what's expected. Treatment needs to be individualized. And like we showed in the first case or two, that try the simple things first. If a guided growth works, then do that as opposed to this big operation with a bulky device. And watch out for recurrence and overcorrection. So, Yogi Berra, right? It's not over till it's over. So it's not over till growth is over. So you got to follow these kids till skeletal maturity. And then, and there you go. And just one final plug, shameless plug. We have a webinar that's coming up on, limb deformity. And this is more, so we also do some global work in low middle income countries. So this is an interesting webinar looking at how pediatric limb deformities are being treated, around the globe, and there's this whole concept of frugal innovations. What could we do with less expensive techniques and devices that are locally applicable? And this concept of bidirectional learning. And you can always visit our website, etc. And email us. If you want to just have a question, you could just look at limb difference at UCSF, and it goes to multiple people, and one of us can answer any questions. Thank you.